Welcome back. That was a great talk by Dr. Krishnan about the endoscopic management of gastroparesis. And now here to talk about the surgical management of gastroparesis, here is Dr. Aman Ali. Over to Dr. Ali.
Thank you, Dr. Paranjapay, for the introduction. My name is Aman Ali. I am the minimally invasive surgery fellow this year for this academic year. Dr. Alon Witkowski helped in making this presentation. I have no disclosures. The learning objectives, we'll look at the anatomy relevant to gastroparesis. We'll look at specifically the historical and current surgical options for treating gastroparesis, and then kind of dive into the perioperative and functional outcomes of the surgery, and kind of look at the importance of patient selection that Dr. Krishnan previously mentioned, and procedure selection as well. Gastroparesis is relatively uncommon, but probably underdiagnosed. In the United Kingdom, the prevalence is around 13.8 per 100,000 patients, and the incidence is 1.5 to 1.9 per 100,000 patients. Here in the United States, the prevalence is 37.8 in women and 9.6 in men, with an incidence of 9.8 versus 9.2 per 100,000 in men. A lot of the causes of gastroparesis were previously discussed, which include diabetes, post-infectious, neuromuscular, and idiopathic. But a relatively common cause of gastroparesis is post-operative, with an iatrogenic injury to the vagus nerve during foregut surgery, such as hiatal hernia repairs, ulcer surgeries, cardiothoracic surgeries, including lung transplants and other surgeries as well. Looking at the gastric anatomy overall, here you see the cardia, the fundus, the gastric body, and the pylorus. On the stomach wall, you'll see three different layers. The outer layer of muscle is the longitudinal layer. The middle is the circular muscle layer, and then the inner layer is the oblique muscular layer. The pylorus is here, and then the duodenum is following that. Oftentimes, for a lot of the surgical procedures, we would have to do partial mobilization of the duodenum. So just to have a broad overview of the anatomy is very important. Some of the medications that were previously discussed, affect contractility of the stomach. For example, with Reglan or metoclopramide, you see antral contraction, but it also reduces postprandial relaxation of the fundus. And this is one of the mechanisms of how some of these medications work. So knowing which portion of the stomach is where and where the pylorus is and how it relaxes to empty out the stomach is important. Giving you a historical context, there's a long history of surgery for gastroparesis, and it predates a lot of the medication that we currently use. Gastric pacing, for example, was pioneered in the 1960s, which I'll talk about a little bit later. And the experiences that we as surgeons have with gastric drainage procedures comes from the era of peptic ulcer disease, where this was before the use of PPIs and so forth that have decreased substantially a lot of the peptic ulcer surgeries that we do today in volume. However, there are many reasons that we still find surgery to be very uncommon with gastroparesis, and a lot of this is because of the outcomes that we see with surgery. But there are new procedures that are popping up, like the POP, for example, with peroral pyloromyotomy or GPOM, which has increased in adoption. And we've also started performing those here at Mass General Hospital. So what are the surgical options? Before going into the surgical options, the patients should always try the non-surgical options first, or the least invasive option first. The non-surgical options include dietary modifications, meaning decreasing fat intake, medications such as prokinetics. I've mentioned Reglan or metoclopramide already. Other medications such as erythromycin, symptomatic improvement medications, including tricyclic antidepressants, Zofran, other things like that. Nutritional support with TPN or tube feeds. Some of the surgical managements of nutrition could include, inserting feeding tubes like a GJ tube or a J tube for example. And this could be done through various different approaches, whether that be percutaneous, minimally invasively, or via an open approach. Other therapies include pylorus-directed therapy with Botox injections, pyloroplasty, or pyloromyotomy, or peroral pyloromyotomy, or GPOM, as we call it. Other therapy options include gastric stimulation, which was first introduced in the 1960s by Bill Gute and his team. And now with the new devices from Medtronic, where I've actually placed 2 of those in, and with variable outcomes. And the last option would be a gastrectomy. And this is like a last ditch approach for patients that are refractory to all the other therapies that I've mentioned. So what about bariatric surgery, and how does it link in with gastroparesis? So traditionally, a Roux-en-Y gastric bypass with a subtotal gastrectomy was a good option for patients with indication for bariatric surgery, patients that were morbidly obese with BMI of greater than 40, because you can basically treat the morbid obesity as well as a gastroparesis with one surgery. Recently, sleeve gastrectomy has been advocated as a procedure of choice to help with gastroparesis, because essentially you reduce the fundal volume in many of these patients, and that's thought to help with the symptoms of gastroparesis. So why do these procedures, or why do these surgeries? Because pharmacotherapy, with all the medications that I mentioned, the outcomes are very unsatisfying, or they're very limited. Oftentimes, some of these medications have really bad side effects. For example, with metoclopramide, which is a dopamine 2 antagonist, was approved by the FDA for therapy for no longer than 12 weeks. Some of the really gruesome complications of Reglan is that it can cause tardive dyskinesia, dystonia, cardiac arrhythmias with QT prolongation. And a lot of the long-term results are not well studied if you look at it. Looking at erythromycin, which affects the motilin receptors, also has its side effects. And a lot of the other treatments that are off-label with tricyclic antidepressants, serotonin receptor antagonists, the antihistamines, and all these other medications have side effects as well. And when you include multiple medications, there's a polypharmacy effect where a lot of these medications compound the effect of some of the other medications, putting the patient more at risk. I believe that surgery, some of the surgical options that I'm presenting have relatively low risk. Of course, the outcomes are unpredictable, but sometimes they're very good. Before any surgical or procedural option, there needs to be an extensive preoperative workup. All patients should undergo a gastric emptying study. They should undergo an EGD as well as labs to make sure they don't have any diagnosis of diabetes or any abnormalities that can be amendable to treatment. And the patient needs to be presented in a multidisciplinary evaluation and fashion. We can also consider anteroduodenal manometry, an endoflip that Dr. Krishnan mentioned, CT, wireless capsule, upper GI, or small bowel follow-through. With the CT, you want to make sure that there's no distal obstruction that's due to malignancy that could be causing a lot of the gastroparetic symptoms. Some of these modalities can also demonstrate pylorospasms or pan-gut motility problems, anatomic problems, which you have to know before you even decide to operate on these patients. If the patient does have a surgical history, then we need to consider if the fundoplication or the wrap is causing some of these symptoms of gastroparesis. So what are the endpoints of surgery? The first things that we need to do in our preoperative visit with the patient is to manage expectations. We need to be upfront. We need to tell them that even after surgery, they may not have 100% complete resolution of all their symptoms. There might not be improvements in quality of life. If they're on any tube feeds or TPN currently, then they may not be able to wean off of it due to nutritional intake requirements. So it's really good to set realistic expectations beforehand. So going into the procedure details, there's different options. The first one would be surgical nutrition. Before you can decide on putting any type of surgical tube in, you need to make sure they can tolerate enteral feeds. Oftentimes we do this with a nasojejunal tube or a Dobov tube, where we're basically feeding the distal duodenum or jejunum to see if they can tolerate any type of tube feeds. Once the patient is able to tolerate that, then we can consider a GJ tube or a jejunostomy tube. Oftentimes, a gastric tube can be used by the patient as a venting or decompression mechanism to alleviate some of their symptoms of nausea and vomiting. But all of these tubes, they have their complications, you know, so you need to make sure that the patient can, first of all, tolerate the tube feeds. The next category would be pylorus-directed therapy, which includes Botox, pyloroplasty, and the new technique POP, which is peroral pyloromyotomy. The first one, Botox, we typically do not perform this. I've actually performed this on patients undergoing esophagectomy. When we have exposure and we're intraperitoneal, we just do a 4-quadrant injection as a drainage procedure, which is only temporary. The reason why we don't perform this is because injecting Botox often disrupts the layers or the different planes at the pylorus, making the POP procedure very difficult to perform, as Dr. Krishna was going through the details of the POP procedure. Pyloroplasty can be performed laparoscopically or robotically. It's a very straightforward procedure. Typically, the patient stays in the hospital for about 1 day. We make sure that they don't have any leaks, and then we watch out for any delayed gastric emptying. Some of the steps of the procedure is that you have to do a partial duodenal mobilization, perform a longitudinal full thickness gastroduodenotomy, which is about 5 centimeters. And then we close this in a transverse fashion with absorbable sutures. And if there is enough tissue, we do a second layer with silk sutures to make sure that there's good coverage. Then we perform an intraoperative EGD with a leak test, and oftentimes postoperatively, we get a swallow study to make sure there's no leak before we start feeding the patient. This is the classic Haneke-Michelitz pyloroplasty that I just described. I also mentioned pyloromyotomy. So with patients that have gastroparesis and they're on like immunosuppressants or steroids that have their wound healing mechanisms impaired, they might be better candidates for pyloromyotomy, where you do not make a full thickness transmural cut. And we've typically performed this on patients that are lung transplant patients that have their vagus nerves ligated and resulting in gastroparesis. A pyloromyotomy might be a better option for them. So as I mentioned, the pyloroplasty is a safe procedure. It's been done laparoscopically and robotically. There's promising short-term results. The long-term results are quite mixed. In this study in surgical endoscopy from 2016, they basically looked at laparoscopic approach and how it's safe and effective as a first-line surgical treatment for refractory gastroparesis. There was 177 patients that were evaluated. Post-procedure, 86% of the patients had improvement in their symptoms, and 77% actually had normalization of their gastric emptying study. Of these patients, 11% ultimately went on to require other procedures for their symptomatic control. Looking into gastric stimulation, as I mentioned before, this is not a new idea. It was first described in the 1960s by Dr. Bill Gute and his team. More recently, Medtronic has come out with devices called the Intera in 2000, which was approved by the FDA for compassionate use of this treatment. And then in 2015, the Intera 2 device came out for medically refractory nausea and vomiting due to gastroparesis. So you can insert the Intera device laparoscopically or robotically. I've done it twice laparoscopically, and it's a straightforward procedure. There's 2 electrodes at the end of the device that's connected, and both of those electrodes are attached at the antrum of the stomach. We use intracorporeal suturing to basically tack it in place. The leads basically go abdominal to abdominal wall layers, and we put the stimulator in the right lower quadrant of the abdominal wall. in the subcutaneous tissue. And then we close up the skin. After the procedure, an external device is often used to set the different parameters because every patient requires different settings and so forth. And these can be adjusted throughout based on their symptoms and so forth. The battery that's actually in the device lasts anywhere from 5 to 10 years, depending on how many stimulations the device is doing. It determines how long the battery will actually last. So looking at the data on gastric stimulation, there's no unblinded studies, and the data is for more than 10 years. There was a French randomized double-blinded crossover trial, which showed 4-month follow-up data of 172 patients. And of these patients, they had improved vomiting symptoms, but it didn't really actually improve the quality of life or gastric emptying. And this has been observed in other studies as well with gastric stimulation, where their nausea and vomiting tend to improve, but their overall gastric emptying kind of fails. As a last-ditch effort, we can go towards a gastrectomy in the treatment algorithm. These patients that make it up to here have gone through different modalities of treatment, whether that's medical, endoscopic, or other surgeries, and they're refractory to all of those, and their gastroparesis is very severe. In this category, you have different surgical options. You can do a total or a subtotal gastrectomy with a reconstruction, meaning that you can do a Roux-en-Y esophageal jejunostomy as one of the options. For patients that are morbidly obese, you can do a Roux-en-Y gastric bypass with a stomach in situ or excising the remnant stomach as a possibility. And more recently, there's been new literature out on the role of sleeve gastrectomy in terms of gastroparesis. Some of the procedural outcomes: the 10-year follow-up after gastrectomy for failed ulcer surgery. There was a study in digestive diseases of sciences, and it showed that in approximately 8 patients that went through various different types of reconstruction, 2 out of the 8 had perioperative complications. There was no mortality, but there were the functional outcomes were quite mixed, but some of them did show benefits. And this was at the time used to argue that more surgery should be performed. More recently, in 2019, at the SAGES conference, as well as a manuscript published in Surgical Endoscopy, they looked at 2 different groups with Roux-en-Y gastric bypass, one with the stomach in situ and one where the remnant stomach was excised with a completion gastrectomy. There was actually more complications with the gastrectomy group at 44.4%. However, there were late reoperations with the stomach in situ group. At the 12-month mark, they did show symptom improvement in the gastrectomy group was limited to nausea and vomiting, but there was no change in pain or bloating. As a surgeon, I favor doing a POP, which is a peroral pyloromyotomy at this time. You can also do a pyloroplasty, which is a good option if you're operating for another reason, such as doing a cholecystectomy or any bariatric surgery that if you're doing at the same time. There's encouraging data with the sleeve that we should look at, and we still need more data on this, but it's a new evolving field using sleeve for gastroparesis. For refractory cases, of course, we need to consider total gastrectomy or subtotal gastrectomy with a Roux-en-Y reconstruction. These procedures typically have higher risks of complications, but you only resort to this if we failed previous other options. So I just want to summarize that surgery is still an option for patients with gastroparesis, especially if there's another indication for surgery and you already have intraperitoneal access, such as with cholecystectomy or bariatric surgery. Surgical risk for some of these procedures is relatively low, and it can be managed with preoperative workup and optimization. The long-term functional and symptomatic outcomes are quite variable, and there still needs to be work that's needed to identify some of the responders preoperatively. We need to keep in mind that all of these patients are very complex, who require a multidisciplinary approach and care before jumping to surgery. These are the resources that I use. Thank you, everyone.